and then I'll give it a second because sometimes it takes a little bit to get in. And you can hear me okay on this mic?
I can hear you fine. Yep.
Awesome. All right, here we go. 3, 2, 1. Hey guys, welcome back to the FOAMfrat podcast. We got a really cool episode today. I am joined with Hudson Garrett, who is an infectious disease guru, is what I hear, which is funny because infectious disease is almost the reason I didn't even get into EMS in the first place. I thought, oh, I'll just be a cop, and then I realized actually they probably get more exposures than we do. But I wanted to start off with just introducing who you are, and actually I'll have you introduce yourself. How did you get into this role? I know you were big during COVID. I saw you on everybody's podcast talking about what EMS needs to do to protect themselves. So how did you fall into this role of having a particular interest in infectious disease?
Completely by accident. I've always had an interest in more emergency medicine and still have a huge interest, obviously, in that. But I was fascinated by all of these people that kept dying from preventable infections. And it wasn't just patients, but it was also, unfortunately, us, healthcare workers. And as you can imagine, over the last 3 or 4 years, there was this sort of epiphany of, wait a minute, we might need to do something, especially for our pre-hospital providers, to protect them more. And it's funny you made that mention of police because, police have the same exposures that we do. The difference is we know more about them and we can protect ourselves. And so I think it's such a critical topic. And so that's why I pursued that. And so I really function on both the pre-hospital and the hospital side. So by background, I'm a nurse practitioner, went and did my doctorate, still work in EMS and have worked in EMS for several years, and also serve as an EMS faculty member for an EMS program as well.
Nice. So what is a day-to-day like? What does your work look like right now? You go in for your shift? Are you working from home? What does a day in the life of Hudson Garrett look like?
It just depends. Every day is very unique. Today, is my home office day. Yesterday was full of stuff with Marburg, and a viral infectious disease that's hemorrhagic fevers. We've got stuff still going on with Ebola. Obviously, there's respiratory diseases. So it's no day is the same. Which frankly I like. I enjoyed that diversity, but it also brings a lot of requirements to maintain your alertness, particularly for us in EMS, where we don't necessarily have the bigger picture of what's really going on with the entire sort of symptomology of the patient. So it can make it challenging, but I think that's also exciting for us too, and makes the job fun.
So do you just like walk around with an N95 on all the time now, just with all your knowledge on what's
Not
floating
at all.
around? No. All right. If you got on if you got on an airplane right now, would you wear a mask?
I do not.
Okay, that's good. I want to make sure because I haven't been, but it's interesting because it was this. I don't know. I'll start off by saying like in EMS when I was first thinking about becoming a paramedic or an EMT, I was like, no, I was a kid, right? And I was like, oh, this would be really fun, but I don't want to get exposed to blood. And you remember in the 90s, there was we were talking about this HIV scare. And there were all these stories that were surfacing that, somebody went to a movie theater and they sat down and a needle was in the seat and it said, welcome to the world of HIV. Or somebody was at a club and they got poked and it said, welcome to the world of HIV. And it was a lot of that was probably bogus, but I remember thinking, no, I don't want to do anything that touches blood. And then I started learning more about it, learning about PPE and some of the protection that you have as an EMS provider. But I remember like when I first got into it, my first couple calls, gown, gloves, mask, but then you do like your ride-alongs and you're like, they're not wearing this stuff. And you see people eating, Qdoba in the back of an ambulance and you're like, okay, maybe this was drummed up a little bit too much. And so I feel like it kind of swings the opposite direction. And then COVID came and then everybody went, I don't want to say too far the other way, but we didn't know what it was. We didn't know how it was transmitted.
Right.
And so it was a scare. And then everybody got really good at PPE. And now we're starting to see maybe a little bit of the pendulum like equalizing a little bit. And now we're pretty good about putting on N95s, tiger masks when we think we need to for the stuff that's always been around, like tuberculosis and, just the regular influenza that's around. And so I'm curious from your standpoint, do you feel like EMS in general right now is better than we were before COVID?
I don't. And I don't want to say that's by any means just EMS. I'm just going to use the term healthcare. You
Yeah.
know, to your point, you know, for 3.5 years, we were living in this world of full PPE, which EMS was, I think, much more uniquely, and fire too, was much more uniquely positioned to handle because we were used to PPE.
Hmm.
But in the healthcare setting, they didn't wear PPE for every patient for months. That was unusual. And so that's been a big challenge for them. But when I look across all of healthcare, whether it's in the ER and pre-hospital settings or outpatient, it doesn't matter. The pendulum, to your point, has sort of swung back and forth almost to a point of complacency in a lot of places. And my whole thing is don't go too far to the right. Don't go too far to the left. Be right in that sweet spot of the middle of what is going to make sure that we have the best safety net for both us and our patients. And do things that make common sense. You know, you made the comment about, do I wear a mask on a plane? No, I don't. But do I have an N95 in my briefcase? Yes, I do. Because, you know, God forbid something happened on a plane and you get called to respond, which has happened to me. You want to make sure you have appropriate PPE anywhere you go so that that can happen. I mean, I used a tourniquet on a lady in the Atlanta airport 2 months ago. You know, she
Oh,
fell
wow.
down yeah, fell down the stairs, had a very, you know, hemorrhagic bleed, you know, pretty serious thing. And there was, of course, no bleeding toolkit anywhere, but I
Hmm.
had tourniquets in my bag. So it's all about preparedness and just thinking ahead.
Yeah. So let's say you and I right now are going out. We're working a shift as an EMS
Mhm.
crew, and
Yeah.
we're going out for somebody who is, I don't know, we'll say unresponsive, might have to intubate them or something. If we're on a
Mhm.
shift, what is the thing right now that's scaring you the most? What is the most threatening type of exposure that you could imagine we would come across in EMS today, like right now, if we were to go out?
I mean, for a mortality, morbidity standpoint, it's those viral hemorrhagic fevers, the things that are really going to drive up the rate of us not surviving, where maybe we don't have a treatment modality too. But the incidence of that, right, is really low. I mean, the chance of that possibly happening to us is very low. So that doesn't necessarily keep me up for the general EMS crew. I think the thing that does is just occupational exposures, getting
Hmm.
splashed in the face, you know, getting stuck and not reporting it. So it's really more behavioral stuff related to it versus in a culture of safety than it is the actual physical exposure. If we have a good culture that says, hey, this is okay to report this, we're going to take care of it, we're not going to make it punitive, then you're going to see a lot more of a difference in the reporting. We're going to have better data. We're going to understand this more, and we'll be able to take care of it more quickly to take care of our colleagues.
Yeah, I think a lot of times as EMS or healthcare providers, like you said, I think we got so tired with COVID at some point, we were like, you know what,
Hmm.
if I get it, I get it. Like I'm
Right.
hot, I'm in the back of a helicopter, I'm in a gown, I got masks on, three pairs of gloves on, I'm on my third call, and just, I got to take a breath, and you're like, you kind of get to this
Right.
point to where you just accept your fate. You're like, if I get it, I get it, whatever. At this point, I don't care. I got to breathe. And I could see that happening when something like COVID comes along and you're forced to just treat almost every patient like they have it
Right.
until you know that they don't have it. And so you had mentioned when we talked on the phone the other day, this viral hemorrhagic fever. And I know that's what you said in the
Mhm.
beginning of this podcast. You were kind of looking into. Is that something that's like up and coming right now? Is that something EMS should be on the lookout for? Like, what you brought that up multiple times. I was just curious. Like, what is the status with that? Is that something that, because it's not something on my radar right now?
I mean, it should always be on our radar. The
Yeah.
challenge is just like Ebola, and it's very closely related to Ebola. Is that stuff never goes away? Whether or not we hear about it or not is a different story, but it is always present there. And CDC has got multiple employees on the ground over there trying to deal with that. And their whole strategy, rightfully so, is to go to the source and try to stop it from ever coming to the U.S. The reason I worry about stuff like that is, your average 911 crew that's going to get that call is not going to be prepared, is not going to probably have good dispatch instructions on what to deal with that, and probably didn't get picked up by the dispatch in call or sort of instructions. But more importantly, they're not going to most likely have the appropriate PPE. So those are the things where you really need more of a specialty response, which there are across the country, but that's not something that the average crew is going to have access to immediately, nor if there's an emergent issue with the patient, they're going to have the luxury of time. So
Hmm.
that's sort of my thing is we've got to think about the situations that might come up and how in a bad situation we can protect ourselves and still provide good clinical care. Those are the things that worry me.
Yeah, and where is that? You said the CDC is on the ground doing like research and stuff. What part of the country is that in right now?
Over in Africa. Yep. So
Over in
most of
Africa.
the viral hemorrhagic fevers are coming from Africa. We see a lot of our other sort of respiratory pathogens come from Asia Pacific region. That's not uncommon at all, and a lot of the mutations take place there. So it's very predictable. We know a lot of the times where these things will come, and we almost even know, in a way, how many sort of iterations are going to come every year, because we can just sort of predict the pattern based on previous history of public health data. So again, it's just one of those things. The nice thing I'm seeing is more and more EMS services are getting trained. Just here in
Mhm.
Atlanta, they're doing a training through Emory, which is fantastic. But sometimes it's difficult to get EMS services that can barely staff trucks to be able to send staff to be able to go. There are great opportunities out there, but we've got to make sure leadership is supporting those so that people can be prepared for these things. But I worry more about those high mortality events that are going to pop up that you don't anticipate, you're not prepared for, you likely didn't wear the appropriate PPE for, that might really harm our colleagues. And that's something that I certainly don't want to see happen.
Yeah, so let's talk about some of the routes of exposure. So you have
Yeah.
contact, droplet, airborne, and vector. I
Mhm.
think contact, droplet, and airborne, we kind of understand. And then is bloodborne, which one would that fall in? Droplet?
It depends. I mean, if you have a broken skin, like if you have a broken, place on your skin, let's say on your forearm, an area that's likely exposed to the patient, unless you're wearing some type of forearm covers, and you get blood in there from the patient, then that could certainly be contact. If you think about you get spit on with blood in the sputum, then now you're looking at something that's going to be a whole different route of transmission. And vector borne is one that I feel like EMS has been very sensitive to due to needle sticks.
Hmm.
But the real big exposure that we see commonly is mucosal membranes. So somebody coughs, spits, they vomit, something like that. And now we've got all this stuff on us. And that's really easy to solve if you're wearing good eye protection. And I find very, very routinely that both EMS and folks in the ER, they don't wear eye protection. And I'm a
Hmm.
huge fan of that. I wear eye protection almost every type of call, just for that simple reason. And it's not your glasses, but it's actual designated eye protection that meets the OSHA standard. And that's really going to be helpful for that.
Yeah, so let's dig into vector a little bit because my understanding of vector was always like an animal and a mosquito and like the way it was transferred. So when you say vector, why is that the word that they use for that? What does that mean?
It's essentially you're taking another transmission route, right? Something that is a physical object like a needle or a mosquito or something like that, and then you're injecting it or entering into the body. So that's why we call it vector borne. So for EMS, we're not worried about mosquito stuff, right? That's not really an occupational
Right.
transmitted thing, but we certainly are more worried about something like a needle, where you have a
Hmm.
needle puncture, and is it a clean needle? Is it a needle with a known source patient that is completely clean and doesn't have any type of disease? Or is it a dirty needle and we don't know the status of that source patient, right? These are all the different things that go through the route. And I think the big concern for EMS is, do you have somebody at your service that understands this or that has the resources to reach out to a professional that can walk them through these steps immediately, so that our professionals that are on the front lines are taken care of? Because some of this stuff is very time sensitive.
Yeah, the big ones that I think of with bloodborne and like
Mhm.
vector on a needle or something is Hep B, Hep C,
Yep.
and HIV. Are there any other
Correct.
ones that I mean Ebola probably should be on that list as well? Would
Yeah,
you
I mean,
agree or yeah?
I would, yeah, I would certainly agree. I mean, it's not one that's, again, going to be really high up on the incidence list. Hopefully so. I mean, because we do a fairly good job of keeping that stuff out, and we
Yeah.
typically know when these patients are here. But yeah, you're right, and there's so much misconception between like HIV and hepatitis. If I had to pick one that I was more worried about, it would be hepatitis B or hepatitis C. The
Even
HIV,
with the
especially outside.
vaccine?
Yeah, I mean, hepatitis B, well, not with if you're vaccinated, but if you're unvaccinated,
Oh, sure.
hepatitis
Yeah.
B can be highly detrimental. But the other thing too in EMS is that it survives on surfaces for months at a time. So if you've got blood on some of our, and we've got hundreds of surfaces that we touch, glucometers, you've got monitors, all kinds of stuff. And if you don't clean and disinfect that stuff, that hepatitis virus can be sitting there, lying in wait, and then you touch it with your bare hands, and all hell breaks loose, right? So our goal is to make sure that we can prevent that transmission up front. But those are the ones that I worry about. And, Hep C, luckily now we at least have a treatment for that, which is helpful. We don't have a vaccine, but we do have a treatment. But even that sometimes can have some side effects.
So you said it can last months on a surface?
Correct.
Wow, that's great. So if let's say I got some blood that's on the ambulance floor or something, and it's
Mhm.
sitting there for a shift, and somebody comes in the next shift and they try to clean it up, or they're not wearing gloves and they get in there, you're still very live, that virus. It can still transfer over there. What about a needle? Like if I had a needle that I had poked somebody with, I'd have to imagine like it's such a small amount that would be on the tip of that. Is there like a duration of how long the needle has to be in? Is it completely dependent on I'm guessing on the scenario? Like, are you more likely to get one of these bloodborne pathogens, viruses from a quick little poke on accident? Or is it more like a puddle of blood that you're cleaning or you get sprayed with? What would you say, like, is the incidence of a poke a lot less than getting sprayed with something?
Absolutely, absolutely. I mean,
Okay.
your risk, luckily so, especially if we're using needleless technologies where they're retracting, is much better. But to your point, there's very very little risk with needle pokes, especially if it's a very quick and you quickly get the blood off and clean it, all that kind of stuff. That's helpful. But your real risk is I get sprayed in the face. I got nothing on my face, but now I've got all this blood on there, and my eyes and my mouth were open when it happened. Right, all
Yeah.
the bad scenarios, the bad the bad juju, if you will, that takes place when you are maybe
And I
talking to the
swallowed.
patient.
Yeah.
And yes, and that. So I mean, everything that could possibly go wrong, the red flag went up. No pun intended with the color, and here you are. So that's the thing that we've got to worry about. And again, I'm a big believer in anticipate the risk. If I'm going to
Hmm.
intubate somebody, I'm wearing eye protection and I'm wearing a mask. And it's not a mask that is like some little tiny surgical mask. It's going to be fluid resistant, and I'm going to be wearing
Mm.
safety glasses because that's something where we absolutely know the risk is there. It's an anticipated procedure. We're doing it. We're purposely doing it. It's not like we can't put on safety glasses that takes 5 seconds. So we need to think a little bit more clearly about, well, wait a minute. This is a patient that's already vomiting. This is a patient that's already had to be suctioned. All those types of things. Yeah, I should probably wear this stuff, but I'm not walking around worried about needle sticks near like I used to. It really needs to be a deep, prolonged needle stick with a high viral load in order for us to see transmission and even prophylaxis. We don't give anywhere as much as we used to 10 to 15 years ago, which is good because of the side effects.
Oh, and you say a lot of that has to do with the engineering controls of having
Yeah,
needleless systems,
yeah, absolutely.
self-locking
And I mean,
needles, all that.
well, and think about something else. You get in the back of a rig. Where is the sharps box that's on the bench seat? And some of the older rigs, it's above your head. So it's on the back wall by the door above your head. Well, what could possibly go wrong if you're bouncing down the road and I'm taking a needle and trying to put it in the sharps box that's above, like basically my eyesight? It's little things like, well, why did we think that was a great idea? Versus, let me put this more at ground level in a box that I can drop it into where I'm likely not going to get stuck, and make it also accessible at the places I need it. If I'm likely to sit here and start the IVs, then I should probably put a sharps box there and make it really easy. But the retractable technologies by far have reduced the incidence of needle sticks to almost zero, which is hugely helpful.
Yeah, we have a sharp shuttles, and I love those because they're in all of
Mhm.
our bags. There's
Yeah.
always one right next to you that you can just drop it in, and you don't got to,
Yep.
hunt for it. Or remember, I mean, people sometimes would take an IO out and stick it in the seat of the ambulance after they pull the needle
Right.
out. It seems
Right.
like it's become a lot more convenient to get to a sharps and be able to dispose of that. And I think that, like, I could totally see why needles sticks have gone down. What's also interesting is I was reading a study where they said EMS providers are less likely to report an exposure if they feel like it was their fault, as opposed
Correct.
to you got a combative patient you're trying to give IM ketamine to, and for some reason it gets knocked out and you poke yourself with it, you'd be like, oh man, that was my fault, I'm not going to say anything. Or, oh, that was the patient's fault, I'm going to report it. Regardless of reporting those, if you have let's say I get an exposure, I have a puncture or something, and I was doing an IM injection, I pulled it out, and then I tried to recap it using a dumb technique with doing it like this, and I hit my finger, and I'm like, all right, there's an exposure, I wipe it off, I tell my program that I have this, and I report it to, I'm guessing that would go to like the safety officer or something like that, that can start that escalation of getting tests. What does that look like? Like if I get an exposure, I go and I tell them,
Yeah.
hey, I have this exposure. What is the proper route to go through? And then can I order that this patient gets tested so that way I can see if they have anything?
Very common question. So first and foremost, if we think about bloodborne exposures, the first thing we want to do is get the blood off of us. So whether it's a needle percutaneous stick or if it's a mucosal exposure. So if it's my face, I'm going to irrigate aggressively. I'm going to use every irrigation fluid I got in the back of that truck. I'm going to get it all over my face, my eyes. I'm going to take some 4x4s, scrub that. So that's the first thing. If it's your finger, squeeze the blood out and then disinfect it. Take some alcohol prep pads, all that kind of stuff. And as soon as you can, wash your hands. The second thing you want to do immediately is notify your supervisor and what we call the DICO. So a lot of services don't really publicize this, but by law, according to the Ryan-White Act, you have to have a designated infection control officer at every service. So this is true for fire, EMS, and police. The same is true in correctional facilities. And so this person is supposed to be somebody with specific training on infection control. There's even now board certification for this area as well that professionals are taking. It's not hugely popular yet, but hopefully it will get there. And that person should really then designate your next steps. Many services, for example, if it's during the day, they'll send you to a local occupational health place, and they'll do a workup if needed. A lot of places also will send you to an emergency department. It sometimes can be advantageous for you to go to the same ER where your patient did. For your sort of the reason that you mentioned about sort of patient testing. So if you're my patient and I say, well, hey, Tyler's needle stuck me and it was, I'd already stuck him. It was a dirty, contaminated needle. Can we get consent from Tyler for source testing? And Tyler says no. It's really up to what the specific state law allows. So some
I'd
states
walk over
do
to his
allow
room. I'll be sitting on the
Yeah.
bed next to him going, you son of a gun.
And a
I'm
lot
just
of
kidding.
cases, patients, will consent. And 50% of the
Yeah.
time, especially those that happen to be in custody for obvious reasons, don't want to consent. And so then there can be a court order. And I've had a lot of success, at least here, going down that route if needed. But it's really all about the relationships you build with the hospitals and also your local police departments and the judges. So if a judge says, hey, look, I've got an EMS professional that's been stuck, they have a right to know if they need treatment. A lot of times, unless there's a law preventing it, they will compel the testing to take place. And so it really just depends on what that relationship is. But your DICO, that person is really the contact and the conduit to make that happen. And our goal is we treat this as an emergency. So you get stuck, we're taking you off shift. We're going to take you right to get care immediately, to get assessed. And the key too, as you can imagine, is to get baseline testing. Because I can't tell you how many times I've ordered baseline testing and the employee popped positive for stuff at the time of baseline testing. And so that then creates a whole
That's why you don't check everybody's D-dimer, right?
Yeah. When you collect data, you've got to have a plan of what do I do with it. So now I've got this employee who just had an occupational exposure, 30 minutes ago, and now they're HIV positive. And we all know that can't take place. So that's not occupationally related. So you got to think about both sides of the fence from a response standpoint.
How often would you say getting baseline tested? Like, you're probably not getting HIV tested every year, but I mean,
no, we would do it at the time of exposure. Yeah, we do it at the time of exposure. Yeah, there's no reason at all that you need to make your crews go get tested just in general. Now, from a general medical perspective, that is definitely something I'd recommend doing at your annual physical exam, but that's not from an EMS standpoint. There's no real medical reason to do that. But at the time of exposure, we always do baseline testing. So we're going to determine whether or not that person is seropositive for any of those, specifically those bloodborne pathogens. And if so, that's going to alter what our potential strategy is going to be. The other thing, too, is to consider their vaccination status. So maybe they had the hepatitis B vaccine series and maybe it wasn't effective and they're no longer immune. Well, that's going to change my treatment strategy. I may give you immunoglobulin as well as a vaccine dose. So there's lots of different options for some of these things. And that's why you really want to work with a dedicated person that understands this world. And that's not going to be just every ER physician either.
One of the things you said we could do better is wearing eye protection, and
Yeah.
knowing about these different viruses and bacteria and stuff. But one of the things we haven't really got into yet is, you said that this virus, Hep B, Hep C, can live for months on a surface. If I take my wet cloth or something and I wipe this down, or I take an alcohol rag and wipe it down, is that getting rid of it? Like, what do I have to use to kill that virus and be like sure that I could like lick the bench seat and I ain't gonna get anything? I don't recommend people lick the bench seat, but you know what I mean. Like, how do you clean this stuff up?
I was about to say, we have to put that disclaimer: don't lick the bench seat. However,
I heard on FOAMfrat that you got to lick it.
Yeah, if you're going to put your Qdoba out there and set up your picnic, the first thing we want to do, right, is make sure the surface is clean. So in an ambulance, it's very likely that there's some gunk or some type of organic soil on the surface. Like, that's very normal for us. So we want to wipe that away, whether that's with a wet paper towel or the disinfectant wipe, which is completely fine. Then we want to make sure we're using a disinfectant wipe that is effective against those pathogens. So that's not all of them. I mean, it is the majority of them in the United States, which is good. And a wipe is probably going to give you your better sort of efficacy just because it's controlled delivery. A lot of people use sprays, which the spray itself, the liquid is great, but what do we do when we immediately spray? We typically wipe it right back up. And so we're not allowing that contact time to adhere there. So
we got to get back in service, man.
That's right. Because you're getting toned out. So, you want to make sure the contact time is adhered to. So wipes are really a good solution because they mechanically remove some of the stuff. They're going to really get down into the surface, which I think is a lot better. And it's more controllable, but make sure you look for the label claims. And so that's, again, something that the crew shouldn't be doing. The DICO at the service should be selecting a product that meets those requirements. So here's what do I tell people you want to have: it's gram-positive and gram-negative bacteria. That's a general rule. Enveloped and non-enveloped viruses are going to take care of your normal stuff like flu, but your more aggressive viruses like Marburg and the Ebolas.
All right, let's break away for a second to talk about a classification of 3 different things you may clean. So there is critical surfaces, subcritical surfaces, and then non-critical surfaces. So we'll start off with the non-critical. So if you come up here, this is a non-critical surface. It's going to come in contact with intact skin. And for this, you want to make sure you get the blood off of it so there's no visible contamination on it. And then you're going to use something like the Sanicide. This is the Cavi Wipes bleach. And you'll read how long you want to have it visibly wet. And you should follow exactly what it says on the container. So this says 1 minute that you want to have it visibly wet. So if I take this out and I wipe this down, you can see it's visibly wet here, and we'd let this sit for 1 minute. Now, some of these used to say 10 minutes, which you can imagine how long that would take, 10 minutes, but it seems like it takes forever. 1 minute seems forever, and you want to just like dry it off, or if you have the spray, you spray it like this, and then you instantly start wiping it, but you want to let it just sit there for a little bit, and that's going to be what kills those bacteria. So it says right on here what it kills. It kills hepatitis B, hepatitis C, HIV, and there's a bunch of bacteria as well. Once that has sat, then you're going to let it air dry, and then you can put your sheets and stuff on there. Now, the other one is going to be your subcritical or critical. And critical are things that come in contact with the bloodstream or sterile tissue that are supposed to be sterile. So if you are using something that is critical, which is not a whole lot, it usually is going to come packaged in a sterile environment. Now, one of the things that we use here at LifeLink 3 is the laryngoscope, and they're stainless steel, and we reuse them because that comes in contact with the mucous membrane that's considered subcritical. And so what we'll use for that is we'll actually use this pure bright germicidal ultra bleach, and we pour it into a container like this, and then we'll actually put the laryngoscope in there. Now, if you read the back of this, it says that you can use it for subcritical or critical surfaces, and you got to leave it in there for 10 minutes. So you don't just take your bloody laryngoscope and just stick it in there. You want to wash everything off of there, get any of the organic, inorganic materials off of it. We got a toothbrush over here. We'll scrub it so it's visibly clean. Once it's clean, we'll put it in here and we'll set a timer for 10 minutes. Once it's done, we'll take it out and then we'll let it air dry and then it can go back into the bag.
One of the big ones that's huge right now, especially if you're going into calls on long-term care, is a fungal pathogen called you've got Candida. So that's another one that's out there, and that one requires a special disinfectant. So if you're using more like of a sodium hypochlorite or a bleach solution, that's going to work well. And there's some other non-bleach solutions that are effective, but that's a big one right now that has very limited treatment options. And it's very difficult to remove from the environment. And then our bloodborne pathogens, right? We're always worried about those. But that's the kind of stuff that EMS has got to think about more because we don't ever know where we're going for that call. And we get a lot of calls.
We're just like,
nursing
throw
homes.
it in the microwave for 30 seconds and it'll be fine.
Right. But the nursing home calls, I think, should particularly concern us because these are long-term residents in a communal environment that don't always get the best infection control practices in there. And then we're getting called when they've been septic for 3 days, as we all know. And it's like, they had a change in condition. Well, yeah, they sure did 3 days ago. It would have been nice if we'd been called then. So it makes it a little bit challenging for us to deal with some of those emergent threats.
Oh, I can imagine. What about Mpox right now? What's your thoughts on that?
It depends on who you ask. It's one of those things that I treat just like any other skin lesion. If you had a weird looking skin lesion, I'm going to cover it and I'm not going to touch it, right? Unless I have the proper PPE to do so. There's no EMS treatment for it. Like we're not going to do anything to treat the lesion. So the only real risk is if we're touching it or being exposed to it. And so again, it goes back to if I see something that's weird, can I cover it? Can I isolate it? And if so, great. If I can't, what's my next best step? And then what do I need to wear to protect myself? That's always the key thing as well. Like putting an N95 on a patient, that doesn't really work very well. It's not fit tested. They're not going to like it. But putting an N95 on us, for example, and then putting a surgical mask on a patient, that's a winning strategy. And that's certainly going to reduce the spread. So we just got to use good common sense. Things that work, things that we have. It's not a perfect solution, but it'll help. And that's what we've got to get towards.
Do you feel like the media blows things up way out of proportion when you see it? Do you like, oh my God, it's not that big of a deal? Or do you feel like most of the time they're pretty spot on?
1,000,000% they do. 1,000,000%.
They blow it up too much?
Absolutely. Absolutely. I mean, if we are getting our medical information from the media, then shame on us. And even as much as
who would ever do that?
I also look at multiple sources outside of the CDC. I didn't used to say that, but I look at many different sources. And I think also our own personal experiences that we have as professionals in a field where we're networked pretty well. Conversations like this matter. Where we can talk openly about these solutions and say, okay, how do we get together, have a shared purpose, and try to make sure that we can do better for our profession and for our colleagues so that, God forbid, when you go home, you don't take this stuff with you. Because we need everybody functioning at full capacity to take care of patients, whether that's a hospital, pre-hospital, it doesn't matter. And the more we talk about stuff and break down these barriers, the better off we will be. But the media is the absolute worst at stirring this stuff up. And I go back to one simple thing. What is the route of transmission? If I know the route of transmission, I know exactly how to stop transmission to me and to other people. And that's what I need to focus on in the back of the box. If I'm going, whether it's a helicopter, which is a whole different animal, or just the back of a ground ambulance, if I know the route of transmission, I can protect myself and I can protect my colleagues during that transport.
Yeah, it was interesting to see infectious disease get politicized during COVID. And all of a sudden, there were different sides on it. And, there would be places that, in certain areas that were not wearing masks, in certain areas that were wearing masks. And it was weird because it's like, well, what's the truth? What's the actual truth behind it? Are you protected with an N95? Are you protected with a mask or not? And, I felt like EMS is trying to get the source of truth, but there is a lot of noise, and you're trying to
Hmm.
find some sort of signal in there of what do I do, and do I follow the CDC? Is that the source of truth right now, or is this politicized? And like I know that was something that I found. You want to believe that the stuff that you're hearing from the CDC is like the most accurate, and that they're very accurate before that comes out. But also, like, is there a delay in them finding something out and then them actually putting it out? And I mean, obviously, there's got to be some sort of a delay because they got to fact check themselves. So, would you say, as far as EMS goes, and I'm sure you may not be able to get into this, but if the CDC puts something out, are you ever going, that's not what I'm going to do?
100%. Yeah. And I mean, I've got a lot of very close friends and colleagues that work at the CDC. And we've had some very straightforward conversations during the pandemic. There's a few that I go to routinely and say, okay, here's your guidance. Here's what happens in the real world. Let's talk about what can happen. And I have to give them a lot of kudos for being willing to have those discussions and said, hey, I appreciate that perspective. Because remember, the folks at the CDC don't practice. They're not out with patients. They're not interacting. They're public health professionals. And so what may be considered public health guidance is not easily implementable by us or a hospital for that matter. And so I think it's important to challenge that and have those conversations, which I've done. And I've had some really good outputs from that. Some things have actually been changed as a result of that. Is I remember when they released the first EMS guidance, I called and I said, whoa, 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 whoa. I said, this has got some stuff in here that this is never going to happen. Like we don't have this stuff. And they said, tell us what you do have. And I said, okay, this is what the average service has and everything. And they changed it. And I was extremely appreciative of that collaboration and they were also appreciative of the call. They said, look, we didn't
Oh yeah.
realize that. This is helpful for us to know. So I think as a profession, we need to do a better job of doing that, but also creating our own guidance. Who better knows EMS than EMS? Nobody.
Mhm.
So it would make more sense for us to have, experts in this field, which there's not very many that can help with that process. But I don't care if the Pope himself came down and told me this is what we're going to do. I'm going to second guess it. That has just been, unfortunately, reality that I think we've all experienced during COVID. And I've never felt that way before. But now I scientifically just have to look at the broader picture and look at all angles. Then also figure out what's pragmatic, too. If I tell you
Right.
to go do something and wear a PAPR for every call on a helicopter, you're going to look at me like I've lost my mind. But if I tell you,
Yeah.
here's when you should wear a PAPR, and we get you one that works in a helicopter and is comfortable with air conditioning, you're probably going to say, yeah, I could do that for that one type of patient that you told me I have to wear this for. Like you could get on board with that. So it's really
Absolutely. Yeah.
about the culture and the science and the practicality. I think all three of those are equally important.
It reminds me of like ACLS, where you're like, okay, here's the
Yeah.
guidance. Like, here's what you're going to work through. But then you talk to somebody does a lot of resuscitation. You talk to an
Right.
ER doc, and they're like, that's not what I do. Like, that is
Right.
like how you group the most good into one guideline or algorithm. But to your point, you have to have critical thinking involved with that, and you
Totally.
can't just be a robot that says, okay, we'll do that. I mean, obviously, if your program is telling you, hey, this is what we want you guys to do, you work for that program. You need to follow those guidelines, but also being able to have some critical thinking, I feel, is really important. And that's really what I feel like the main message of this episode is looking at each situation a little bit different, being aware of what these things even are, how long they are living on surfaces. The term fomite was used a lot during
Yeah.
COVID. Is fomite just the thing that a pathogen can live on?
Yeah, it's anything that's non-living. So any of our inanimate objects, our environmental surfaces, our glucometers, our pulse oximeters, our stethoscopes, pulse oxes, all of that stuff that's in the back of the units, that's all considered a fomite. And each of them is going to be different. And just for context, you can take a really, simple device like a glucometer And we've had outbreaks of hepatitis B and HIV with those because people misuse them. And the example that unfortunately happened was the glucometer itself wasn't the problem. It was that people bought the ones from like Walgreens or CVS, and they were using those lancing pens, the ones that you put the lancet in, you'd cock it back, you'd hear this god-awful cock, and it had a
Yeah.
spring inside. Well, on the box, it clearly says not for use in healthcare settings and not for use between patients. Well, people bought them because of supply chain issues, or they were cheaper. And then we had a bloodborne transmission because they were changing the lancets, but all the blood was getting in the spring. And so every time the new lancet would go on and it would puncture the next patient, it was transmitting. So, even the smallest and simplest of things that we use have risk. But the good news is if we sort of are constant about our approach, that's the key. And I think if there's one thing to walk away with is COVID was, for many, a wake-up call as far as how broken our system is in terms of preparedness. I was never afraid of COVID. Not once I was afraid of COVID. I was afraid of all of the Band-Aids that were ripped off and the hemorrhages that were created in healthcare. And I think we all experienced those: staffing, supply chain, culture issues, safety, you name it. But I always go back to, if I can focus on three basic things: hands, surfaces, and skin. I want to keep my hands as clean as possible with an alcohol-based hand sanitizer or soap and water when possible. I'm going to make sure that I keep my environmental surfaces that I use, like especially my computer keyboard. I'm going to keep that nice, clean, and disinfected. And then I want to keep my skin and the patient's skin intact, which in medicine, we have a problem. If you have a hole, we plug it with something. So we're making breaks in the skin, whether it's IV catheters or NGs or ET tubes or anything. So we sort of have a problem there already, and the body doesn't like those artificial things. So we've got to focus on those three areas, and that'll keep a lot of this stuff at bay. Just those simple efforts.
Oh, Hudson, I can't thank you enough for coming on, man. This has been fantastic. And before we leave, I want to ask you, if you had to pick the dirtiest thing in the ambulance, if you were to go through and find the thing with the most pathogens on it, what would it be? What tool? Stethoscope, pens, clipboards? What would be the dirtiest thing you think you would come across?
I can tell you, based on culturing ambulances, that it's the monitor.
The monitor,
at least
really?
at least in the analysis that I've done. I mean, which is probably a couple hundred units, but it's the monitor. Just because we've become so overly reliant. The screen.
Really? I could see that, because you're putting it on a patient and touching it with your glove and stuff, and
right. And we're so overly reliant upon automatic vital signs. Every patient gets the monitor put on them, so it makes sense. I think that would have probably been different 10 years ago. But yeah, the touch screens, and a lot of that too is the touch screens are not really compatible with a lot of the disinfectants. So that's been a challenge for us as well. So sometimes people don't wipe them down with disinfectants, which can create an issue.
So everybody right now is going to be like going out to their ambulance and wiping down their monitor. If you had to wipe down the screen of your monitor, what would you use right now? Alcohol?
The absolute best thing. Yeah, I mean, a big alcohol wipe, like a 70% alcohol wipe, actually works really well. But there are some disinfectant wipes that are compatible. So you just need to check with the manufacturer to see if it's compatible with your touchscreen, because you don't want to break down the touch part of the screen itself, which can take place with some of the disinfectants. But there are some that are compatible.
Awesome. All right. Thanks so much, man. I really appreciate it. If anyone has any questions, do you mind if we give out, put your email address in the show notes of this?
Sure. Absolutely.
Awesome. Sounds good. Thanks, Hudson.
Thank you so much.